Get started. Thank you, Selena, for recording the meeting. Slides and the video of the meeting will be posted on the SMCI website. So please share with your colleagues. Other housekeeping is, if you can be on video, that would be great. Questions can go in the chat, and I will be monitoring it throughout the meeting today. And please make sure you're on mute throughout the talks to minimize the extra noise disturbances. So welcome everyone. Should I introduce myself first? I'm Samantha Kling. I'm quantitative research scientist with the Evaluation Sciences Unit and have been helping SMCI coordinate this lecture series. And I was so excited to invite Justin and Maria to present this amazing project we collaborated on a couple years ago now. But to get started, Maria Alushin is a clinical associate professor of dermatology. She received her Bachelor's of Arts from the University of California, Berkeley, and then went on to receive her medical degree from David Griffin School of Medicine at UCLA. She also completed her dermatology residency at UCLA and served as chief resident. Her clinical interest included general dermatology and inpatient dermatology, and she led this particular quality improvement project we'll hear about today. Justin joined Stanford Medicine in 2012 and serves as the director and chief of medical dermatology at Stanford Healthcare and is the physician improvement leader for the ICDB projects. He spearheads the dermatology department's efforts around network development, digital health, quality safety, performance improvement, and value-based care. And it has been a joy working with Maria and Justin on this project. And without further ado, I will hand the mic over to Justin.
Awesome. Thank you so much, Sam. It's a pleasure to be here today. We're so incredibly excited to have the opportunity to share with you, share this work. And hopefully those listening on recorded session, you guys are the Stanford Medicine Improvement community and really excited to have that community to learn about what it is that we did. I wanted to provide some big picture context and themes around the work before I turn it over to my amazing colleague, Maria Alushin. She was the brains, the bronze, the animating force behind this effort and the leader of our project. I was particularly excited and proud of this effort, which for us was the first formal improvement project that we did along an intersection of care, right? So it's akin, I use the analogy of shining a bright light into one of those dusty corners in your home. And these are places where, as we all know, patients, they're sort of left on their own oftentimes. Care team members often feeling like they have to step in with manual workarounds and superhuman efforts just to hold things together in this space that typically doesn't get much attention or light. And the result of these care gaps, these gaps in care coordination, can result in patient frustration, family member caregiver frustration. We can see clinical effects in quality, right? We can see deterioration after discharges leading to a readmission, representation to ED. When we look at the clinical team side, the clinical team and the clinicians, oftentimes they bear a logistical and cognitive burden. This is something that they hold with them because they know that without that, things can fall through the cracks. And truly, each one of the quintuple aims, if we just think across the IOM definition of quality care, each one of these can be diminished when we don't have the proper attention support systems in place here. So we're really excited not only to show you what we found, but some of the things that we did in terms of interventions and things that we continue to do around this particular care coordination intersection in leveraging some of the workflows, systems, digital care capabilities. I think and I hope that as you think about your work and the areas that you interact with, you'll see some parallels and maybe see some similar challenges And we would love to connect and see if there are themes or areas or ways that we can engage or work with you or collaborate. These are really tricky places to do improvement work because they're complex. There's a lot of players involved and not a lot of established systems and processes. And so we were really fortunate, incredibly fortunate, to have traveled this path alongside a lot of great collaborators and individuals across the institution who help support this. And really notably, I want to thank our Evaluation Sciences Unit colleagues for being true partners in this work and bringing their expertise, their experience, and their guidance to that. So I'd love to turn the floor over to Dr. Alishin to talk about what it is that we did.
Wonderful. Thank you, Justin, so much for that wonderful overview. And thank you, Sam, for the kind introductions. It truly was a joy to work alongside you both on this project. And thank you all for joining. I'm so excited to share what we've been working on over the past 2 years. The title of the talk is Improving Transitions of Care in Dermatology, a Collaborative Effort. And I can't stress that enough. This truly was a collaborative effort, which is why I want to start off by introducing the members of the team. You've already met myself and Justin Coe, but there was another person in the Department of Dermatology that played a huge role, Dr. Bernice Kwong. She's a fellow colleague of mine that also helps run the inpatient dermatology service. But beyond that, we also had nurse coordinators, residents, front office staff, so many others that were a part of our team. And as Dr. Coe already mentioned, the Evaluation Sciences Unit, we can't thank them enough. They really kind of joined us every step along the way. They served as our teachers, our mentors, and we're so grateful for all of the support that we received from them, as well as the ICDP team. So a little bit of background on transitions of care. And what I mean by transitions of care are specifically as patients are transitioning from the inpatient to the outpatient setting. It's no surprise transitions of care are complex. It's an extremely vulnerable time for our patients. Some studies have shown that after discharge, about 50% of patients may experience an adverse event, which could be related to medication continuity, diagnostic workup, or test follow-up. 20% of patients are readmitted within 30 days, and it's speculated that 75% of these cases may be avoidable. There was an interesting study that looked at PCP follow-up within 4 weeks of discharge, and they found that patients that did receive follow-up within 4 weeks were actually 10 times less likely to be readmitted. We also know there's a huge cost associated with readmissions. It costs almost $15 billion per year on readmissions in 2010. So you can imagine that number has likely gone up over the past decade. So the bottom line, we know transitions of care are challenging, and timely follow-up may be able to prevent adverse events and prevent readmissions for our patients. So we are not immune to this problem within dermatology. We have a very robust inpatient consultative dermatology service at Stanford. We see over 1,500 patients per year. About 40% of those patients need their simple visits just to ensure that a rash has resolved, and other patients need ongoing longitudinal care. Our team is made up of 5 inpatient faculty that rotate every week and 2 rotating dermatology residents that rotate every month. We actually have 2 services. We have a general dermatology inpatient service and a supportive dermato-oncology service, which is dedicated to taking care of patients that have underlying cancer diagnoses. And it's no surprise to all of you, we take care of a lot of high-risk immunocompromised patients. So it's really important that we get this right for them. So this project was really inspired by some of our patient experiences, some of the things that we were noticing as our patients were transitioning from the inpatient to the outpatient side. And there were several near misses, and there were several cases where our patients did, quote unquote, fall through the cracks. And I wanted to share a representative case. So this is a 46-year-old female that presented with drug-induced hypersensitivity syndrome, formerly known as DRESS. They were treated with steroids, were doing well, and were discharged on prednisone. And the plan was for them to follow up with us within 2 weeks. The inpatient primary team placed a referral, which was a non-urgent referral, which was processed about a week later by our new patient coordinators. There were no appointments available, so multiple messages had to be sent to find an appropriate appointment. An appointment was found, but unfortunately the patient no-showed to their appointment. It wasn't until the end of the rotation when the residents were checking their log and noticed that the follow-up for this patient was incomplete. At that time, they frantically were messaging faculty and schedulers trying to get an appointment more urgently for the patient. But unfortunately, at this point, the patient had run out of prednisone and was readmitted for renal failure secondary to their DRESS. So fortunately, this is a very rare occurrence, but when this does occur, it really resonates with us. So this really kind of served as the inspiration for our project. We wanted to see what we could do to improve transitions of care for our hospitalized patients and prevent adverse events and readmission rates. So we were able to identify a potential problem, a rather large problem, but where do we go from here? I personally had no quality improvement experience before we delved into this project. So we were so fortunate to have the support of our department, our chair, as well as Dr. Ko, who encouraged us to submit a proposal as one of 3 core departmental improvement projects. And we were fortunate enough to be selected to partner with the ESU team. And we were having such a good time and we're learning so much and wanted to continue our work that we actually ended up applying and continuing our efforts through the right project. So the main overarching goal, and this is for our World Cup fans out there, was to improve for our hospitalized dermatology patients that required outpatient follow-up. But this is a rather large, hefty goal. So the way that we went about approaching our project was in 3 steps. The first step was identifying the problem even more. The second step was coming up with solutions to the problem. And the third step was evaluating the intervention. So the first step, identifying the problem, we really had to go back to the beginning. So that included doing interviews with all of our stakeholders. We realized that we actually didn't really know what everyone's role and responsibilities were in the discharge process. So the stakeholders included our derm inpatient attendings, our residents, our new patient coordinators, our front office schedulers, our patients, which our ESU team helped interview, as well as insurance representatives. So we really wanted to learn everyone's roles and responsibilities, but we also wanted to hear their pain points with the current workflow. After talking to our stakeholders, we were able to come up with this ideal process map. So what are the necessary steps that it takes for a patient that's in the hospital that needs outpatient follow-up to actually end up in our clinics? After talking to our stakeholders, we also summarized some of the key themes that were emerging over and over again. And there were 3 key themes that emerged, the first of which was lack of standardized process and structure with our current workflow. It was deemed non-standardized. We had different workflows for new patients that were being seen in outpatient follow-up and for our return patients. We also had different workflows for our general derm service as well as our onc service. There were multiple communication channels. Oftentimes after a referral was placed, our residents were also sending emails, staff messages, text messages to our schedulers to ensure that our patients were being scheduled. When our referral was placed, the urgency was often not specified. Sometimes it was routine, sometimes it was marked as urgent. And oftentimes our schedulers mentioned that there was insufficient scheduling info in the referral, which made it difficult for them to schedule patients in a timely manner. Another theme was burdensome manual tracking. Unfortunately, we had no automatic way to track which patients were scheduled and which patients completed their visits. So instead, our residents were manually tracking, and this was incredibly time intensive, as you can imagine. There were also incomplete patient expectations, which we learned from talking to our patients and our schedulers. Our patients oftentimes didn't understand the need or the importance for follow-up. Oftentimes they quote unquote had bigger fish to fry than following up with dermatology. Our schedulers also were oftentimes unable to reach patients, or if they did reach patients, they had trouble explaining why a follow-up appointment was recommended for them. And there were some simple things like there was an incorrect patient number that had been listed, which was why a scheduler wasn't able to reach the patient and schedule an appointment. There were also larger structural barriers that played a role, like limited appointment availability and issues with insurance authorization, which affected a small subset of our patients. Another overarching theme that emerged was burnout amongst our stakeholders. Our team was overwhelmed by the intensive patient tracking. There was a lot of uncertainty and stress and fear of losing patients to follow-up, which resulted in chart stalking, basically meaning close tracking of individual patients and incoming derm outpatient referrals, which you can imagine could greatly contribute to burnout amongst our stakeholders. So once we had all this information, we went back to our initial process map and we updated it and we incorporated some of the pain points that we learned from our stakeholders. And you can see that our process map became much more complex. And we really utilized this as a way for us to come up with possible interventions. And we really wanted to come up with interventions that would address multiple pain points without increasing the workload for our stakeholders. So this takes us to the next step, solutioning the problem. So one of the interventions that we came up with was a SMART phrase. So SMART phrases are abbreviations or words that are used to pull long phrases or paragraphs into a note, or in our case, a referral. So this is an example of a SMART phrase that anyone can create with an Epic and share with appropriate team members. This is what our SMART phrase looked like. This SMART phrase contained all the necessary information that was needed by our schedulers to schedule an appointment. So we specified what the reason for the referral was, if this was a new or a return patient to dermatology, how soon did we want them to be seen? Did the patient want to be seen by video or in person? Where did the patient want to be seen? Did we need an interpreter to schedule the appointment? And then also, most importantly, what number should we be calling to reach the patient, and who should we be reaching out to? Should it be the patient or the caregiver? We then used the SMART phrase and we inserted it into the referral. And so we standardized this approach. So before, some people were marking referrals as routine, some were marking them as ASAP. So instead, we decided that all referrals would be marked as ASAP. From talking to our stakeholders, we had learned that an ASAP referral was processed within 2 days as compared to 7 days for a routine referral. And then into the comment section, we would place the SMART phrase. And again, this was to help facilitate providing all the necessary information for our schedulers. We also standardized the approach that the referral was placed by the inpatient dermatology team as opposed to the inpatient medicine team. So at the time of discharge, we would verbally tell the medicine team that we would take care of the referral ourselves. And this was, again, so we could help standardize the workflow. So the SMART phrase was much more than just the SMART phrase in terms of our intervention. It really came alongside a whole new workflow. And this new workflow was trying to address some of the pain points that we had encountered earlier. So the first of which was lack of standardization. So as I mentioned before, all referrals were now marked as urgent or ASAP. We now had the same process for both new and return patients. We no longer required emails or staff messages to be sent. All communication would occur only within the referral. And then a SMART phrase was always used within the referral to ensure that there was complete scheduling information. To address the burdensome manual tracking, we weren't able to fully address this, but we hope to alleviate some of it. Our referrals were now being routed back to the ordering provider in order to close the loop. To address incomplete patient expectations, the SMART phrase was completed at the bedside with the patient. So at the time of discharge or at the time of the dermatology team signing off, the resident would meet the patient and explain that we felt either a follow-up appointment was necessary or not. And if it was deemed necessary, we would explain the rationale as to why we thought the follow-up was necessary. And we would gather the correct phone number and contact information to reach the patient. So in this case, we were really engaging patients in their care. So here we again went back to the process map and we updated it with the SMART phrase. But for the sake of time, I'm not going to go through all of this in detail, but we wanted to take a look at the predicted impact that the SMART phrase would have on the pain points that we have previously identified. So the final phase was evaluating the solution. So the main objectives that we were evaluating were to assess the impact of the SMART phrase and the associated workflow on timeliness of scheduling and completion of follow-up, but we also wanted to take a look at messaging workload during transitions of care for dermatology patients. The next aspect was to explore key stakeholders' perceptions of the impact of the new smart phrase intervention in post-discharge scheduling. So we did a mixed methods approach. We had quantitative and qualitative analyses. On the quantitative side, we used 2 time periods that we assessed: pre-implementation of the smart phrase and post-implementation of the smart phrase. And again, we looked at timeliness of scheduling and completion of follow-up. And we utilized the electronic health record for this. And then the second aspect of our quantitative study was to look at in-basket messaging in Epic, which was used as a proxy for total communication. And we extracted data for our inpatient dermatologists, our derm residents, and our scheduling team. For the qualitative side, we conducted semi-structured phone interviews, and we interviewed, again, the inpatient dermatologist residents, as well as the schedulers and the new patient coordinators. And this is where ESU team helped us out tremendously. So early on, not surprisingly, we did hit some bumps along the road. There were some unforeseen staffing shortages. We noticed that the smart phrase was being inconsistently used by our residents, and the referrals were not being marked as ASAP, all of which led to scheduling delays. So we had to make some adaptations. So we did onboarding and training of all the stakeholders regarding the new workflow. We updated our smart phrase, and at the top, we specified that this referral needs to be marked as ASAP to serve as a reminder. And we also sent email reminders to our residents. We updated our inpatient handbook. We did a verbal sign out, and we held lectures to disseminate information about the new workflow. And you can see over time, with these adaptations, the use of the smart phrase did increase most recently to 100%. Similarly, the percent of referrals that were marked ASAP also increased to almost 90-100%, so near consistent use. So looking at our results, so here we're looking at pre-implementation and post-implementation. We can see that in these 2 time periods, there were a little bit over 100 patients that were seen by the inpatient service, of which about 50% were scheduled for an outpatient follow-up. So the same amount of proportion of scheduled patients was seen both before and after implementation of the smart phrase. And similarly, the proportion of completed follow-up was also the same, so that there was no effect on the number of scheduled patients and the number of patients that completed follow-up with the implementation of the smart phrase. But what was most important to us was the timeliness of follow-up. So before implementation, 45% of patients were seen within 2 weeks of discharge, and 2 weeks is really kind of the gold standard that we use. We hope that most of our patients can be seen within 2 weeks post-discharge. After implementation of the smart phrase, you can see that this number went up to 68%, which was statistically significant within 2 weeks. We also looked at messaging data, and we saw that the number of messages that were sent in total before and after implementation of the smart phrase in the workflow decreased significantly. It also decreased for all of our stakeholders, our dermatologists, our derm residents, as well as our staff. What we can see is that the difference is most drastic for our residents, whereas for our staff, it's less so. We speculated that there was a shift of messaging from our residents to our support staff. Similarly, we looked at the number of patients that required messages to be sent pertaining to scheduling, and you can see as well there's a steady decrease pre-implementation and post-implementation. For our qualitative analysis, we spoke with our stakeholders about their perceptions of the smart phrase, and it was well received. Similarly, nearly all dermatologists, residents, and scheduling staff reported improvement in their workload, stress, and/or well-being. And this is what one of our residents mentioned. The smart phrase does decrease workload in terms of hours, our time spent on documentation and administrative tasks. One of the biggest areas that can lead to burnout is the documentation burden. So I think the smart phrase definitely helps with that. Early on, when we were implementing our intervention, some dermatologists and residents didn't notice a significant difference. They felt there was still a lot of back and forth messaging that was required. The smart phrase also facilitating setting patient expectations. Again, the smart phrase was completed at the bedside with the patient, so it prompted having these bedside conversations. It would identify the appropriate contact for scheduling by discussing this directly with the patient. And it also ensured that our patient and caregivers understood the importance and the purpose of the follow-up. And the hope was that this would potentially reduce the risk of last-minute cancellations or no-show appointments. So one of our residents mentioned the most important thing was that we got all the information we needed from the patient without having to go back and ask. Having that checklist to know all of the questions to ask was probably the most helpful thing on our end. So it was helpful that the SMART phrase was well received by our residents, and it did not increase their workload, which was really important to us. The schedulers also mentioned that patients are informed about the referrals, so they expect us to call them. So in summary, from the first phase of our project, the proportion of patients scheduled and the proportion of completed visits did not improve. However, most importantly, the proportion of completed follow-up visits within 2 weeks of discharge did significantly increase. Messaging pertaining to patient scheduling decreased overall. And then qualitative interviews amongst our stakeholders revealed near universal improvement in workload and well-being. And it was universally felt that the SMART phrase was well received. So here we're going to rewind back kind of to the beginning. Sorry about that. This was all occurring during the pandemic. So COVID was amidst, and we were implementing video visits. So we really wanted to take a look to see what effect video visits would have on transitions of care in dermatology. So I'm calling this phase 0 because this was really happening before we even were thinking about our SMART phrase. So the objectives of this phase of our study were to retrospectively evaluate how teledermatology affects clinic capacity, scheduling efficiency, and timeliness of follow-up care for our dermatology patients transitioning from the inpatient to outpatient setting. And we also wanted to assess perceptions amongst our stakeholders of teledermatology for post-discharge follow-up for our derm patients. So we again conducted a mixed method analysis. On the quantitative side, we looked at 3 different time periods in this case. The first time period was before teledermatology was employed. So this was before the pandemic in 2019. Our second time period was early teledermatology. So this was early on in the pandemic, and then sustained teledermatology, which was the following year in February to May. And the 3 things that we were really looking at were clinic capacity, which is defined as the number of appointments that were scheduled, scheduling efficiency, which was defined as the average days from hospital discharge to scheduling of an in-clinic visit, and then the timeliness of care. So the days from hospital discharge to completed follow-up visit. On the qualitative side, we again conducted semi-structured interviews with our stakeholders, and we also had conducted interviews with our patients to learn about their experience with the discharge process, and we asked about their perceptions regarding virtual care. So the results from this intervention regarding clinic capacity, teledermatology or video visits increased clinic capacity by 36%. You can see at baseline, 92 patients were scheduled, and then that number increased to 125 post the pandemic, and this was sustained. And similarly, the number of completed visits also increased by 36%. The next thing we looked at was teledermatology use. Before the pandemic, none of our patients were being seen via video. However, during the beginning of the pandemic, almost 2/3 of all of our follow-up visits were done by video. And this was sustained, but did drop significantly to 47% the following year. The last thing we looked at was timeliness of follow-up, and we did not see any difference in the proportion of completed visits within 2 weeks. You can see that pre the pandemic, about 50% of patients were seen within 2 weeks. And actually this number decreased quite significantly at the beginning of the pandemic, but there were other factors at play, like staffing shortages that likely played a role. And then as the pandemic was sustained, you can see that these numbers returned back to the baseline. We also looked at scheduling efficiency, and we did not find any statistically significant improvement in scheduling efficiency. So again, looking at baseline, it took on average 4 days for an appointment to first be scheduled. However, oftentimes appointments had to be rescheduled. So we also looked at the number of days it took for the final appointment to be scheduled. And again, it was 9 days at baseline. And you can see that these numbers got significantly worse early on in the pandemic, again, alluding to some of the staff shortages and lack of clinic availability that we saw. And then over time, as the pandemic continued, you can see that these numbers returned closer back to normal. From our qualitative interviews, we also wanted to learn more what the stakeholders felt about the acceptability of video visits. And some of the positives that were mentioned, video visits were felt to be flexible, convenient, increased access, and were helpful in terms of patient preference. We also wanted to take a look to see if there was any difference in use of video visits based on age, and we didn't see any difference based on age, looking at individuals under the age of 71 and over the age of 71. However, we did notice that patients that lived more than 21 miles away from the clinic, they had more follow-up done by video, which was statistically significant. Some of the negatives that were discussed were poor photo or video quality, inability to access a smart device for some of our patients. There would be an inconvenience if our patients needed labs or procedures, which we couldn't facilitate by video. And then some of our patients had discomfort with tech. So one of the clinicians commented, "Sometimes I feel like the quality of care is there, but it's not as good as in person." So summary of these results: there was rapid adoption of video visits for post-hospital follow-up early in the pandemic, and this was sustained, but to a lesser degree as the pandemic continued and COVID-19 restrictions were lifted. Teledermatology increased the clinic's follow-up scheduling capacity by 36%. Scheduling efficiency and timeliness of care transitions did not improve, but recall, this was occurring during the pandemic, so there were other scheduling challenges and restrictions that were in place. Interviewees viewed telederm as an important care modality, though limitations do still exist. So we wanted to comment on the sustainability of these two interventions, the smart phrase and the use of teledermatology. And I'm happy to report that the smart phrase is still being used. It's been successfully integrated into our workflow. There's a near 100% use rate. One of the residents commented here, the smart phrase, it's definitely sustainable. We're very familiar with it, so it's easy for us to use. Teledermatology, it's still offered for post-hospital follow-up visits, and about 30% of our visits are conducted via video. And one of the clinicians commented here, one of the few silver linings of the pandemic is that we do have this robust application of video visits that we're all able to utilize. Of course, there are still some persisting challenges that remain. Appointment availability, it was still an issue. We still had to do manual tracking, and insurance authorization for a subset of our patients was an ongoing challenge. So just recently, we had asked our derm residents to track how much time they spent manually tracking patient results and scheduling, and 2 residents spent on average 51 minutes per day doing this manual tracking. So you can see this is still a large challenge that we're trying to address. So some of our future directions, or not so future directions, to address the appointment availability, I'm happy to report that just last month, we launched our first discharge clinic, which I'm leading. It's based out of Hoover. We've had 4 clinics so far, and it's been about 80 to 100% booked, and about 30% of our visits are done by video and 70% are in person. So hopefully that will address some of our issues with appointment availability. In terms of need for manual tracking, some of our future directions, we're hoping to, at some point, have a discharge coordinator or liaison that can help with some of our keeping track of our patients, whether they've been scheduled or not scheduled, and having an automatic dashboard, which we had started working on as part of our RIGHT project. And then insurance authorization, that's something that we will work towards addressing in the future as well. So I learned a tremendous amount throughout this quality improvement project. I'm continuing to learn every single day. Just some advice to others, as corny as it sounds, teamwork truly does make the dream work. I can't thank all of the team members enough. Change, no matter how small, can be hard. An example of that, clicking the referral and marking it as ASAP, it was really hard for that to be adapted, but don't be discouraged, keep problem solving. And I'm happy to report that now nearly all of our referrals are marked as ASAP. It's really important to talk to everyone involved in the process, both before, during, and after implementation. I learned a tremendous amount about the importance of qualitative interviews. They can identify facilitators and barriers early in the process, which can be used to make changes. And then I learned the importance of using multiple quantitative metrics, which can help you identify where your intervention is working and where it may not be. So thank you all so much for joining today, and I'm happy to answer any questions.
Thank you so much, Maria. That was a wonderful presentation. And I see we have a couple questions in the chat. Shalane Nolan, would you be able to come off mute to ask your questions, or would you like me to read them out loud?
I'm sure I can do that. Hi, thank you guys so much for a great presentation. Really appreciate the learning and the sharing of your process and the journey. I was just curious, I had a couple of thoughts about the changing things to ASAP as the order, and I was wondering if you were able to tell if that affects the coding and the billing, because of course I assume there's a different charge for urgent appointments versus those. And then a very similar question about access, and I'm just curious, right? If everything is urgent, then how do you know what really is? So just curious how you manage when you have a real urgent need to schedule.
Yeah, thank you so much for those wonderful questions. I wasn't aware that there could be a different charge associated with appointments if they needed to be marked more urgently. The main issue that we came upon was actually insurance authorization. It can take quite a bit of time for certain patients to be authorized by their insurance to be seen. So that was one of the limitations that I didn't talk about. But for those patients that needed to be truly seen in an urgent manner, that was something that we sometimes had to work around. But I actually wasn't aware about potential differences in billing. So would love to chat more offline if that's something that you're aware of.
Oh, I'm not an expert on from the other direction. We do have a whole coding team. It's a question though. One of the reasons they may be getting pre-auth sooner is because you said it's urgent, not because it's routine. And that's an interesting question, whether it's cutting in line or being efficient. It's just a question for our coding team. We have people to help. We've got lots of people to sort that out with.
Oh, I would love to. I would love to chat more about that because that's definitely important for us to know. And then you had also mentioned. I'm so sorry, I didn't mean to cut you off.
Okay. Say nicely.
You had also asked about if we were marking everything as ASAP, how could we truly tell what was urgent and what wasn't urgent? So the same new patient coordinators triage referrals that are coming from the hospital as well as from the community. So we wanted to make sure that the referrals that were coming from the hospital kind of wouldn't be overlooked. And then within the referral, we do have the smart phrase, which better specifies when the patient needs to be scheduled. So if they need to be scheduled within a month or within a week or within 2 weeks, we have that kind of granular data available within the smart phrase for our schedulers to see. We basically just wanted to make sure that a coordinator would see the referral within a few days in case the patient needed to be seen urgently, so they wouldn't fall through the cracks.
Right, thank you. I appreciate it. It's just questions. This is important work to be doing. We've got to try all sorts of ways. I agree with you.
Oh, absolutely. And yeah, I really appreciate you guys asking us these questions and making us think more about kind of the interventions that we have implemented. And by no means are they permanent. We are always looking to adapt and change and improve moving forward as well.
Yi Zhang has a question in the chat. Would you like to ask your question?
Oh, hi. Thanks for this wonderful presentation. I just have a quick question regarding the reimbursement from insurance, if it's a televisit or it's a like in-person follow-up after the discharge. Would you mind talk a little bit about that process? Also, you mentioned about its insurance take a long time to do that. I just wonder if you can talk a little bit like how long it's gonna take, what's the why it's like take that much long time? Thank you.
Yeah, thank you so much for the great question. I'll answer your question about insurance authorization. So what we learned is different insurances require different processes in terms of getting authorization. So some of our referrals that we were placing actually weren't being scheduled because we learned that the referral had to be placed by the patient's primary care provider. So I think the issue with insurance authorization is actually a lot more complex, and it was a little bit outside of the scope of this project, but certainly something that we would love to explore more moving forward, because I think there is a lot of variability in terms of the different workflows. And then you had asked about reimbursement. From what and please, if someone knows the correct answer, please correct me. I think that initially the reimbursements were similar during the pandemic. I don't know if those numbers are still the same, but I would have to take a look and get back to you. But if someone happens to know the answer off the top of their heads, please feel free to unmute and share.
Great. And then the next question was submitted by Keith Fisher. Would you like to ask your question?
Sure, thank you. And thank you for a wonderful presentation. You mentioned about in-basket messaging in Epic. Did you switch to that being the sole communication tool? Because some of us use Epic or Outlook or Volt or text messaging, and you question somebody, why didn't they see their Volt message or their Teams message? Did you see did you switch to just that as being the sole communication tool, and how does that improve the response rate, or even lessen the confusion between where they should look for their messages regarding patient care?
Yeah, thank you for bringing up that really, really important point. That is something that we noticed as well, that prior to our interventions, the way that we were communicating with our schedulers as well as with each other really varied. Sometimes we were sending Epic messages, staff messages. Sometimes we were sending emails, sometimes we were text messaging, and we did want to try to look at how the messaging rates decreased with the implementation of the smart phrase. But because we couldn't capture all of those modalities, we couldn't go back and count text messages, emails, and staff messages. We just looked at staff messages as being representative of the total number of messages that were sent. But you're absolutely right. The way that we were sending messages and communicating varied tremendously. With our smart phrase intervention, we actually stopped sending messages altogether. Before, it was part of our workflow to send a message along a referral. We were kind of doing double the work, but we wanted to put faith in our new intervention, and we actually stopped sending messages altogether. And then if messages were being sent, there's a way that you can message within the referral. So when a new patient coordinator receives the referral, they can actually leave a message within the referral that other people can see. So that was the primary mode of communication that we were using. Of course, there were still some instances where things were not happening in a timely manner. And in those cases, we mainly relied on communication through staff messages. So that's why when I presented the data on the before and after, the staff messages didn't go to zero as we would have hoped in an ideal world, but they decreased significantly. Thank you for the wonderful question.
Marcy, would you like to ask your question?
Oh yeah. Hi, Maria. I feel thank you so much for this great presentation. I was just thinking, oh my gosh, we did so much more. Like you put everything together. I'm like, no wonder I was breathless after the end of this project. Anyway, I'm so surprised that there's still such a need to monitor the charts so closely for patients. And I'm just wondering if you have any depth of understanding of why that is still such an issue.
Yeah, thank you, Marcy. It's so good to see you. And you're absolutely right. This was a tremendous amount of work amongst all of us. And I'm just presenting a portion of it. So yeah, it's so good to see everyone. So I think one of the reasons why we're still, quote unquote, chart stalking or monitoring our patients so closely is the system is still not 100% effective. And until we get close to that, I think there's still this fear of patients falling through the cracks and being missed. And so I think until we get there, we're going to have this desire to check up on our patients. I think eventually we had been working on a dashboard with Melissa, who played an instrumental role, a huge role in this project as well. We wanted to come up with a way of doing it automatically. So instead of tracking patients manually, having it be automatically done, but there were still some kinks that we were working out with that dashboard. And then eventually we're hoping that instead of our residents having to do a lot of the work, that this could really be transitioned to a discharge liaison that would kind of help oversee the whole process. And they would work closely with me, who's running the discharge clinic. That way we could kind of have a weekly meeting time that we could review all of the patients that we had seen in the hospital and ensure that they were scheduled and had been seen in an appropriate manner. But I think it's still, Marcy, to answer your question, there's still a fear that there could be some patients that could fall through the cracks. So we're still manually following them. And besides just checking in on scheduling, we also do track their labs and their results and their biopsy results. So there's still going to be a need for some manual tracking, even if we get the scheduling down.
I'm just wondering, I know when we were working on this, there was definitely an element of like trusting the new system. And so that's, I guess, why I'm particular. I like, are you actually keeping track? I'm just wondering how much is just still being afraid to let go versus, yeah, we still have some loopholes. And if you can just comment on that.
Yeah, so I think that there still have been those situations where there have been patients that were kind of quote unquote near misses, even with our quality improvement project. So even though our patients, we're seeing them sooner, and we have made strides in kind of those improving kind of the timeliness of follow-up, there still are those patients that we may be missing or may be falling through the cracks. So even though there's been kind of improvements in the right direction, until we're kind of closer to 100%, I think even if we're missing a few patients, that's enough concern for us that we're still choosing to manually track and make sure that we're catching those patients before they end up in the hospital.
And Laura Vaughn, would you like to ask your question? I think we have enough time for 1 to 2. So this might be the last question.
I was just wondering how often you ran into trouble with patients being like they didn't have insurance or they were out of the Stanford's network or authorization. And did you have a system that managed those that fell into that category?
Yeah, thank you. That's such an important question. And unfortunately, we didn't come up with a good solution for that. I don't have exact numbers, but there was enough of those patients that we were noticing trends. And it was actually from talking to our insurance authorization individuals that we learned that this was an issue, that certain patients do require that the referral be placed by their primary care provider and not by us. So it was actually really helpful that we communicated with our insurance folks, but we haven't yet made any changes to kind of figure out possible solutions on that side. And absolutely, that's something that would be in our kind of future directions work. I don't have the exact numbers for how many patients fall into that category. It's not a huge number, but like I mentioned before, even if it's a small number, those patients are oftentimes at higher risk for falling through the cracks. So it is important for us to address this moving forward.
Great. And I think we have one more question, or I have a question. So at the time of our evaluation, we were not able to capture like smart phrase use through the EHR because it was buried in the note, hard to capture. But I see you have data on that. What was the process to be able to extract this use of the smart phrase?
Yeah, no, thank you for asking that question. So a part of that was done through the RIGHT project. And initially we were tracking that manually, but we were working with Melissa, who was helping us build a dashboard. And she, through so many different avenues that are kind of beyond my scope of understanding, was able to figure out a way that we could actually collect data to capture when a smart phrase was used within a referral. So that is something that has been built into our dashboard, but it's not something that we're routinely using. But initially we started out tracking it manually, and then with the help of Melissa, we were able to automate the process.
Great. That's so good you have that data, and I'm so impressed it's at 90% usage rate. That is awesome. So to wrap up today's presentation, thank you again, Maria and Justin, for presenting this project. And just wanting to let everyone know, we will be starting the seminar series back up in January on Tuesday, January 10th. It is at the normal new time, and it's with Dr. Baraka Floyd from Pediatrics, and she'll be talking about diversity, equity, and inclusion in improvement science. So super exciting presentation. If that does not get on your calendar, please reach out to SMCI. Either Selena or Lisa Freeman will help you get the Zoom information on your calendar. But thank you, everyone, and I hope everyone has great holiday season.
Thank you, everyone. Thank you for the invitation. Good to see everyone too. Bye.
Thank you.
Bye.
Bye-bye.